Assalamualaikum dan salam sejahtera. Anda sedang menonton Agenda AWANI dan Agenda AWANI sentiasa melihat kepada akar umbi, tetapi hari ini saya perlu berbicara dalam bahasa Inggeris. I have to speak in English because we're looking at a very, very important aspect of our society that if you're sick, you just want to be cured. You just want to get better. But what if you're sick, you want to get better, but you can't get better not because there's no cure, but because you can't afford to get the cure. And the public health system has always been discussed. It has been discussed here. I remember discussing it across 3 health ministers already. So, but in the days and age of Malaysia Baru, where are we? So it's very interesting that that's one thing that cut across politics, especially in looking at how to help those who are under serious threat from hepatitis C. And this has started even from the old government era, which is now having better news in the new government era, on the new Malaysia. But I'm no expert in this matter, so I have 3 very interesting speakers on this. They are all our guests to this country right now, so I would like to try, because their names are very exotic in the sounding. Closest to me is Leena Menghaney, Medicine Sans Frontier, MSF. And then we have Sonjelle Shilton, the project director at FIND. And this is the toughest fight. Jean-Michel Piedagnel from France. He's from DNDI. DNDI is a very interesting organization. They're a non-profit organization. From the beginning of their DNA, they are a coalition of movement and expertise, and they look at diseases that maybe others don't look at because there's no commercial value, or they don't want to go there because it's tough, and they make it possible for people who are afflicted to get treatment. One of the initiatives that is being looked upon more and more, and also to Malaysia and Thailand, for example, as an example for the rest of the world, is in curing hepatitis C. So I'm just going to go straight to it. Hepatitis C is a blood-to-blood kind of disease. If you get a blood infusion that was, infected with the virus before, maybe 30 to 40 years ago when the screening was not as tough like now, and then you'll be carrying it for decades, not realizing that you have it, because you can't see it, you don't feel it, and suddenly it comes out and has the symptom. And it can affect the liver very, very badly, and causes a lot of death and suffering. And in Malaysia, I think between 400,000 to 500,000 people afflicted with this. The problem before, when I look at the figures when I was reading is, you're looking at thousands of US dollars for a set of regime over weeks just to be cured. And there's crazy side effects, which makes the patient really, suffering through the process. So now there's good news. So I let you guys talk about the good news, why Malaysia is at the forefront, because we can't just leave it to chance. And this is one greatest example where government has to intervene, because if left to market forces, people will be suffering and dying, even though the cure is just beside their house.
Yes, I think the element also that we need to bring in is that these new treatments are a revolution. We are moving from a time where treatment was complex with a lot of side effects, as you mentioned. People were suffering a lot taking the treatment to try to cure hepatitis C, and they had 1 chance out of 2 to be treated. We are now, with these new treatments, in a time where the chances to be treated have increased over 90–95%.
Okay.
There is no side effects. So, this revolution, what we feel is should be brought to everyone. It is time now that we can get rid of that disease. We can eliminate hepatitis C. And this is quite an incredible moment and news in terms of public health. And this is what Malaysia, especially the Malaysian government, has engaged in, taking a world leadership in promoting access to treatment for hepatitis C. And this is really unique and exceptional.
Why has it taken so long just to come? I know it's fast in terms of the revolution, but why didn't it happen 10 years ago, 15 years ago? Is the only main obstacle money and commercial aspects and the whole thing about big pharma, or is it just the political will?
So first of all, these treatments are fairly new. You're talking about 5 years. So they are recent, they've been found very recently. And then there was a very high price tag to these treatments. We are talking about $60,000 US for one 12-week treatment.
Okay.
You know, this who can afford that? No one. This is the price of a car, of a house in Malaysia.
We kept being told before that the big pharma has to do it that way with patents and right, because they spend billions in R&D, in research and development to find cures like this. These are the frontiers of medicine, virus that we cannot fight before. In order to find the cure, they need to invest a lot. So where do you stand in this debate?
I think Leena is the perfect person to answer that question.
Please jump in anytime. Don't have to wait for queue.
Yeah. So what is very interesting, and a lot of people do not know this, that Big Pharma's strategy is to buy molecules which have actually been developed by public labs.
All right.
So actually taxpayer money went into the development of these drugs for hepatitis C, and then they were bought like any other investment by Big Pharma. And subsequently, they were sold at an astronomical price. So you had government paying for research, but then the public couldn't access it at an affordable price. And that was the irony in the United States. But it also happened to impact people in developing countries, because when you talk about $60,000 in the US, the government and insurance schemes couldn't afford it there. So you can just imagine that people in developing countries just couldn't possibly think of paying that price.
But surely government wants to give cure. Governments would want to give cure to people. How did that happen?
So governments want to treat people, and civil society always puts pressure on governments to treat people, and for that you need public health programs. But public health programs need affordable generic medicines. So you can't possibly pay $60,000 or even $12,000 per patient. You need to bring it down to a price where you can treat everybody universally. And that's why you need competition and you need generic medicines.
We have laws around the world regarding trade.
Yes.
And pharmaceutical product also will be governed under that umbrella. So the WTO TRIPS give the ability for a government to issue a license, sort of. That's how I understand it. I was reading the book, it was so technical for me. But the way I understand it, if the failure of the market to provide solution to cases of diseases that afflict people of that nation, the government can issue that license. Was that the option taken by the Malaysian government?
Absolutely. This was the legitimate right of the Malaysian government to protect its people. And they did it a decade and a half for HIV/AIDS, and they've done it again for hepatitis C. World trade rules don't block governments from saving lives. They actually allow governments to go out there and allow competition where monopolies have been abused. And this is where the bullying has started from multinational corporations who disregard these rules and overstep and try to tell and dictate to governments what they should be doing.
Why was Malaysia not included by the big pharmaceutical company that, come out with the cure and the drugs? You're going to have to mention the name of the drug. I'm bad with pronouncing it. India was one of the places chosen to manufacture the generic version of that drug that they have the patent to. Malaysia was not in the list, which gives Malaysia the right to say that, hey, I want to use the license for my country because I'm not included in that. My people are dying and suffering, so I have to do that. But what's behind the thinking of people with the patent of drug in selecting which country included in the list and which country to manufacture and stuff like that? What goes into the thinking?
These are pure commercial interests. So they look at middle-income countries as pure markets. And they look at these middle-income countries as pure markets of people, for a pocket of rich people who can pay for their drugs, and then leave behind everyone who can't pay for those drugs. So Malaysia is a lucrative market for Big Pharma. So is Ukraine and many other middle-income countries. So is Brazil, for example. And none of these countries are ever included in the list of countries who can manufacture or be supplied with these drugs. So it's basically pure commercial interest that dictates Big Pharma policy.
But now we are in the list, as in Malaysia. So what do you think the option is? Because the Malaysian government and the Ministry of Health has gone with this combination of drugs with the DNDI. Research has been proven. I saw the presentation online and everything, peer reviewed and everything else. So do we have two options now, going with the one that we are looking at today in this discussion, plus the one where the big pharmaceutical company has included Malaysia in the list for their combination of drugs?
So Gilead reacted to the Malaysian government's step of thinking about a compulsory licenses and decided to include Malaysia in the list. But what Malaysian government did was perhaps one of the most interesting steps that you can think about. They made Indian generic companies compete with Egyptian generic companies and get even a better price, one. Okay. Two is, we've seen that the Malaysian government is investing in local production. And this is a very important step in terms of technology, because you saw Brazil build its capacity when the HIV/AIDS crisis happened, and they decided to make HIV medicines, and similarly Thailand. So Malaysia too has a legitimate right to produce medicines, and this is really very important.
Okay, I don't want.
The success of the Malaysian strategy is that it's not just the starting point was research and development with us, but now it's encompassed more than research and development. It's about local production, transfer of technology, looking also at screening, simplifying the algorithm of screening of when people get to the primary healthcare clinic and how fast they can get treatment. Okay. And it's also a partnership with a local manufacturer. So this partnership, and also talking about it, what we are doing today is making public and increasing the knowledge and the awareness about this disease. So it's a full package, and that's really the backbone of the success of this strategy in Malaysia, led by the Ministry of Health.
Okay. Sometimes we need a model for developing nation because the models out there are too alien to us. Even your testing the genotype has got to be localized in this area. But I don't want to exclude America, as well is from America. President Trump has spoken about the big pharma and everything else. So I'd like to have your view on it, because our current Prime Minister moved for high technology and building local capacity. Maybe the argument should also be vociferously debated within the local Malaysian pharmaceutical industry of R&D, scaling up, and also awareness of the people. But who's going to do this? The market, the government, because we know government will never be as efficient in most cases, if not all, than the private sector and the market. So if we have a test case like this for hepatitis C, how can we do and replicate the same thing across other types of diseases? Dengue, for example, is killing a lot of Malaysians, and there's no cure in sight. Right, so we have to go for a break. Once I'm back, I'll let the American in the room speak. But this is a very serious issue, and we're all for making people better and curing them if there is a cure for them to share. Imagine quite some time ago you had a medical emergency where you need blood transfusion, and 3 to 4 decades later, suddenly you feel so tired and know there's something wrong with you. You went for a checkup and you've been diagnosed as having the dreaded hepatitis C virus in your body, and it's affecting your liver. But then you're being told that if you want a cure, it's there, but maybe it's going to cost about 30, 40, 50, 60,000 US dollars. And a lot of people in Malaysia, we're still talking about going day to day and the cost of living, 60, 40 or 30 or even 12,000 US dollar is not good enough. That's what we're talking. A revolution has happened. The government of Malaysia, the Ministry of Health, the DNDI, their partners have, all the hard work has been done. Now, the cure is there in Malaysia, right? At any time, correct? Do I get that correct? But we want also to learn the lessons from this revolution. So over to you, Sonjelle.
Thank you. So I'm with FIND, and we're actually an organization that's based in Geneva, Switzerland.
Yes.
And what we do is we work on developing diagnostic technologies for diseases that may be neglected or not well developed for. So I think you asked an interesting question about scale up and how do we learn from these lessons. So now that we have the treatment, we've got to find the people to be able to provide this treatment to. So you mentioned that up to 500,000 people in Malaysia are living with hepatitis C. So how do we find those people? And what we have done is we're very happy to partner with DNDI because of their long-standing partnership with the Ministry of Health. And last summer we signed a Memorandum of Understanding with Clinical Research Malaysia on behalf of the Malaysian government to implement this project. And it's bringing WHO qualified diagnostics down to the lowest level of the health system. This is allowing people to come in and get screening for hepatitis C to know if they need to go to the next steps of the care cascade and then access this valuable treatment.
How do you localize approaches like this? Because each country has its unique characteristic. For some in Malaysia, they live in very remote areas, like in the tropical rainforest, where you need to take maybe 2 days boat ride. So do you make the diagnostic kit more rapid and mobile in terms of its essence, so that they don't have to go to the clinics, but the the people that is behind this can go to them, for example?
Yeah, that's an excellent point. So our project on hepatitis C, it's called the Head Start Project, and it's funded by a funder called UNITAID. And we work in 4 countries, of which Malaysia is one. And in each country, we're doing various aspects of what we call decentralization. So that's bringing the screening test as far down to the people as we can. The screening test is a rapid diagnostic test, so you can just use one finger pick of blood and then see if you've been exposed to the virus. In Malaysia, we're starting by introducing these screening tests in 25 of the clinics, so the primary healthcare clinics. And then we want to understand how that works, the lessons learned, and then we would love to see that model even scaled up further to increase the reach.
Before I go to the non-Americans, I'm very interested from the data perspective, because these are the days of big data, artificial intelligence, deep learning and machine learning. How can we use all this together with all the things that I've spoken about, so that we have a more targeted, specific, like a war room, where we can trace this virus to the single cell that is creating havoc in?
So from our perspective, it's using volumes of data to understand where and who are affected by this virus. So we want to screen up to 45,000 people through this project. And that will allow us to see in each area, different area of Malaysia, who needs this screening? Is it vulnerable groups, general populations? And then when you compile that picture, you can best target your public health efforts.
So we might possibly see the tendency of certain group to have this more than others, or a geographical location and stuff like that?
Yes, yes. It depends on the country. In some countries, it's older people who had blood transfusions before we started screening. In other countries or areas, it's vulnerable groups. So it depends on your location.
Do you start with the blood transfusion data?
It depends. So it depends on how good the data systems of the countries are.
How good is Malaysia's data system? I'm very curious.
So from our experience, it's quite robust.
Okay.
The capacity for the hepatitis C data system can be grown, and I think that's one of the things that we will have the chance to do working with DNDI.
Well, this government has promised this country that it will be a very rule of law and transparent country. So I'm going to keep on following up with you. Jean-Michel, you want to add on to that? Can we now close a bit of a chapter on hepatitis C? It's just more the implementation of it, and look at other diseases now. I'm very curious about dengue, for example.
Well, you ask what have we learned, and once again we have learned that when patent is used to establish a monopoly which increase prices of treatment, we need ways to break that monopoly. So in the past we've used the supply of generic drugs from other countries such as India. But what we have done, which is quite unique in Malaysia, is the starting point was research and development.
Okay.
We said, if prices don't go down, we have a treatment coming up and it will be cheap. Okay. We've already have a price, it's $300 for 12 weeks. It's as efficient as the other treatment. So just that threat, because remember that treatment is not yet available, just that threat was enough to bring prices down. So that's what we have learned, and that's what can be replicated in other disease areas such as cancer, dengue. Dengue is a bit special. I mean, there is no, there is research and development, but it's so far, it's not been that successful.
Correct.
But we could also create a coalition.
Are you looking at it already?
No, we are not. No,
not yet.
We are quite busy
so that can start
already.
in Malaysia. Another revolution after the hepatitis C.
Yes, we are ready, but we need a coalition, you know, and it's expensive. It's very expensive.
Okay, Leena, that expensive part, but I promise them that you're gonna, pronounce the name of the drugs for us.
Okay, so the names of the drugs are supposed to be daclofenacin and ravidasvir for people to remember. But I also wanted to highlight that, Thailand and Brazil and India all have used the ability to produce medicines and deliver public health programs. And Malaysia seems to be at that turning point. So it's a strategy of not just access, it's a strategy of access plus innovation. And I think Malaysia should stick it grounds with the United States.
But
on
it's
that.
expensive, Jean-Michel said.
Yeah. Well, it's expensive, but...
How much public money should be dedicated for this?
For hepatitis C?
For all diseases that's not
public
cured,
health?
that's killing thousands of people.
Well, from a public health point of view, the cost of not treating is greater than,
the cost of treating.
Absolutely. So, for example, if you look at, if you don't treat, the virus goes further and other people also get infected. If you don't treat, people get cirrhosis.
The reason I ask is because we have tried so many things. Before they were even trying to bioengineer the Aedes mosquito, which I don't think has worked, but more and more people are getting in. So that's millions of ringgit Malaysia or US dollars. So how much was it for hepatitis C virus to get that revolution?
So developing drugs is expensive. Huh? It's at least, first of all, it's 10 to 15 years for one drug. And there's no way you can cut that. So it's expensive. It's very expensive in some cases with big pharma. The highest cost is actually the cost of failure. You do a lot of try, and you fail a lot, and that's the case with dengue. There's been a lot of attempt, and so far not a lot of positive outcome. But what we can see in Malaysia around HCV is you can create an ecosystem, and in that, if that ecosystem is transparent, works, you can bring in investment from private.
You're my new friend because transparency is important. The media has to play a role, but not everything has to be new. We have a lot of public universities in this country. We have pharmacy and schools and medical schools around. Can't this be networked together?
Yes, absolutely. I mean, when I came to Malaysia a year and a half ago, maybe a year ago to work on hepatitis C, I know that, for example, Malaysia, there are generic companies out there who have developed imatinib, one of the most successful cancer medicines, and they actually developed it, and it's sitting in their labs, but they can't be sold because of patent barrier. Now, imatinib is one of the most expensive cancer drugs in Malaysia. You have generics in the United States, you have generics in India, but the Malaysian people and the Malaysian government can't buy imatinib at an affordable price, despite having the technology to develop imatinib. Now, if Malaysia wants to look at this strategy in a larger way, then is to look at how you can address patent barriers, not only for hepatitis C, but for drugs like imatinib, which are life-saving for chronic myeloid leukemia patients.
So if we don't do anything, we have to wait for the patent to expire. Which is what,
Malaysia
2 decades?
Well, Malaysia is one of the last countries where the imatinib patent expires due to evergreening. So Big Pharma has been extending its patent in Malaysia quite successfully in imatinib. So the irony is that you have a generic in Switzerland, it's a Swiss company who developed it. There's a generic in the United States, but no generic in Malaysia. And that's how they are misusing the patent system in Malaysia. And that's very important to address.
The access to drugs, essential drugs, for public health purposes is not going to happen unless we challenge, but by engaging more in market solutions. So we need to actually have more public commitment to research and development so that we challenge what is essentially often a monopolistic situation. That's what we have done. You know, we have said, here is competition.
So you move into their strong areas and generate yourself.
And that can only happen with more public commitment. And in the case of Malaysia, you're right, the competence is here, the know-how is here. It's just about organizing it.
Okay.
And I think what we see is it's possible with hepatitis C.
And it doesn't have to be a lonely fight. Countries around the world can unite through initiatives like this.
Absolutely.
Right?
Yes.
So you guys have to come every month at least. We have to promise that to the people of Malaysia. Awareness is key. If you don't start the discourse, you do not collaborate. If you do not collaborate, you will be at the mercy of the big giants. And they are big giants. Thank you so much, Jean-Michel, Sonjelle and Leena, for making time to be here. Thanks to you. There's a lot of people behind the camera. Thanks to them for bringing great people here. But this is about us. Ini tentang Malaysia baru, bukan hanya politik dan wang, tetapi kesihatan itu yang paling utama dan bagaimana kita memikirkan sains, teknologi, pembangunan, pendidikan, malah pattern dan undang-undang antarabangsa. Inilah yang mahu kita saksikan dibincangkan di Dewan Rakyat di Parlimen Malaysia. Terima kasih kepada kumpulan ini yang melakukan revolusi. Kini hepatitis C tidak lagi membelenggu kalau kita berikan penyelesaiannya, dan penyelesaian itu kini boleh dibeli pada harga 100 sebulan untuk 12 bulan, misalnya $1,200-300 Amerika. Terima kasih kepada semua DNDI, Fine dan juga Leena, my new friend. Lepas ini kita akan bincangkan di tahap lokal bersama dengan Kementerian dan juga syarikat farmaceutical Malaysia. Itu episod seterusnya. Jumpa lagi.